How's it going, guys? We have a past level question for Gastro Step 1 Pediatrics IM Surge 2CK, 2-day-old male, born 39 weeks gestation at term. Recurrent episodes of bilious vomiting after feeds. Physical exam shows slightly distended abdomen. No other abnormalities noted. Question wants to know which of the following was appropriate next step in diagnosis. Let's just hop through the answer choice here. Choice A. Abdominal ultrasound, wrong fucking answer. In pediatrics, this is going to be for pyloric stenosis, which can show us an olive-shaped mass in the epigastrium. Sometimes that can be palpated. You're going to have non-bilious forceful projectile vomiting. It's non-bilious because clearly the pylorus, the anterior of the stomach, is proximal to where the common bile duct enters the duodenum, so you're not going to have bile within the emesis. And USMLE also wants you to know that pyloric stenosis is a one-off developmental anomaly. In other words, if you get a question like cleft lip, palate, VSD, ASD, these are usually polygenic phenomena, but they're one-off, i.e. they're not part of a greater syndrome. Ultrasound? Wrong fucking answer. Choice B, abdominal x-ray, correct answer. We're looking for the double bubble sign consistent with duodenal atresia. 9 out of 10 times can be annular pancreas as well. So duodenal atresia, I've talked about how Down syndrome can cause duodenal atresia as well as Hirschsprung disease, but they need not be associated. They can be idiopathic. Annular pancreas embryology is described as failure/abnormal migration of the ventral pancreatic bud. So we have bilious vomiting here. It's the past level component, right? So bilious vomiting, that's going to be duodenal atresia or annular pancreas. You do an x-ray looking for the abdominal x-ray looking for the double bubble sign. If you have non-bilious vomiting, that's pyloric stenosis. You're going to do the ultrasound looking for a mass, sometimes described as an olive-shaped mass in the epigastrium. Tangentially, real quick, you should know of something called pediatric GERD. Just know it exists, okay? So it's going to be a kid who has non-bilious, mild/light coughing up of milk with feeds 2 to 3 times per day. That's how they can describe it, okay? So you'll be eliminating to get there. Like, doesn't sound like pyloric stenosis. Doesn't sound forceful. There is no bile in the emesis. And you narrow it down, and the answer is just decreased lower esophageal sphincter tone, okay? And you're going to do positional therapy. So position the child upright after feeds. Use thickened formula, can put rice within the formula. Last resort for recalcitrant pediatric GERD is going to be Nissen fundoplication, which they ask on one of the pediatrics forms. Let's just hop to the other answer choice here. Choice C, enema, wrong fucking answer. It's going to be diagnostic and therapeutic for intussusception. So intussusception, we have a telescoping of the small bowel, can be due to viral infection or vaccination, e.g. rotavirus. And you're going to do ultrasound first to diagnose, but as I just fucking said, enema is diagnostic and therapeutic. So enema is more definitive. So in other words, if they ask you for the next best step and both are listed, choose ultrasound, but they usually don't list ultrasound, don't worry. And enema just straight up is going to be the answer. It doesn't matter what kind of enema. It can be water soluble, barium, air contrast, air, tap water, doesn't fucking matter, okay? And that the ultrasound controls the target sign. The enema will just clear it. Now, patient's going to be described as classic recurrent squatting, vomiting, crying, blood in the stool, sometimes bilious vomiting, and there's going to be a sausage-shaped mass classically in the right lower quadrant. Okay? Now, this is important that there's a mass in the abdomen because this is how you differentiate from congenital midgut volvulus where there's no mass, but the presentation can sound like intussusception. And that's a high-yield learning point, especially when you hit 2CK pediatrics, where there's a question on one of the forms where they say a kid has intermittent squatting, crying, vomiting, there's blood in the stool, and you're like, well, that sounds like intussusception. And the answer, and they tell you in the stem, they say there's no mass, and the answer is volvulus. Intussusception's wrong, and students are like, what the fuck? Well, as I said, they can sound similar. So mass, intussusception, no mass, volvulus, they can both sound that classic picture of intermittent squatting, crying, etc. So they can also tell you x-ray of the abdomen if they do it, which is interesting because it's not part of the standard diagnostic sequence. But if they happen to mention the x-ray finding for intussusception and volvulus, it's going to be dilated loops of small bowel with air fluid levels. It's a non-specific finding. It just means you have a GI obstruction. Enema? Wrong fucking answer. Choice D, insertion of NG tube, wrong fucking answer. So this is going to be for tracheoesophageal fistula, where proximal esophagus ends in a blind pouch, and you have the distal esophagus connected to the trachea. Okay, so if you insert an NG tube, you're obviously going to you're going to insert that and hit the proximal esophagus. So that they're going to describe that as a kid who's coughing up milk with initial feeds. You can also do insertion of an NG tube for choanal atresia. So choanal atresia is when you've got the nasal passages that are not patent. The kid will be described as blue while breastfeeding, and then he's pink upon detaching from the breast / crying. Wrong fucking answer. Choice the upper GI series, wrong fucking answer. So this is going to be for congenital midgut volvulus, as I talked about before. So they can give you the classic picture where it sounds like intussusception, but then they say there's no mass. You're going to do an upper GI series. This is going to be a barium swallow or gastrographin swallow plus x-ray of the abdomen to look at the anatomy, which can show a corkscrew shape. So the way they can do this is essentially two main ways. The first, they'll give you a big fucking paragraph. You have no idea what's going on. They'll show you an x-ray that looks like a corkscrew. That's an upper GI series, okay? Because you're looking at that x-ray with the barium or the gastrographin and a corkscrew, and the answer can just be failure of rotation of proximal bowel, okay? And the other way they can do this is give you a big fucking paragraph and then don't show you an image. But they say in the last line, upper GI series is performed, and you're like, well, that's volvulus, because I know that that test is done for volvulus. So your take-home point here, the pass level component, is if you have forceful projectile non-bilious vomiting, that's pyloric stenosis. If you have vomiting that is bilious, you are going to do an x-ray of the abdomen showing a double bubble sign. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.